Welcome, everybody. It's so great to see everyone in person. I feel like we can all go, we're all here together. So thank you so much for coming to this event. I'm so excited to be with these wonderful panelists. My name's Elizabeth Cohen, and I'm a medical correspondent with CNN. And we're going to be talking today about firearm violence. And I have with me Jerome Adams. Dr. Jerome Adams is an anesthesiologist and executive director of health equity initiatives at Purdue University. He formerly served, as you all know, as the U.S. Surgeon General and Commissioner of the Indiana State Department of Health. And he's frequently on CNN, so that makes us happy. Dr. Megan Ranney is an emergency room physician and academic dean at Brown University School of Public Health. Dr. Ranney is co-founder and senior strategic advisor for AFIRM, which stands for the American Foundation for Firearm Injury Reduction in Medicine here at the Aspen Institute. Dr. Barsotti, Dr. Christopher Barsotti, is the other co-founder of AFIRM. He is an emergency room physician in Vermont and co-founder and former CEO of AFIRM, which is now at the Aspen Institute. He is also a certified 4-H youth firearms trainer, and I had the good fortune of being in Vermont about a year ago and watching him do his work with those children, and it was really an amazing program that you run there. It was really terrific to see.
I'm glad to be a part of it.
Yeah, it was great to be there. So we're going to be talking about firearm-related deaths and injury in the U.S. More than 45,000 a year, unfortunately, far more than any other developed country. It is now the leading cause of death among young people. It's overtaken car accidents. Of those deaths, suicide is the leading cause, followed by homicide, and then mass shootings is a much smaller percentage. With Uvalde and Buffalo and those tragedies fresh in our minds, and we try to work to prevent all of those deaths from happening, we need to consider also that about 40% of American households own guns, most of them legally. And there have been various approaches to address this problem, some changes in laws, regulations, and policy, and other changes that don't involve policies. And so these three speakers are speaking at a very a timely moment as the Senate is considering the first bipartisan firearms legislation in a generation. We're going to be taking questions from the audience. We'll talk a little, you'll talk a little, we'll talk a little. One request that I'll make more than once, which is this is obviously a topic that people feel very strongly about, as we all should, and that when you ask a question and don't make a speech, because these are our experts, and we want to move this along. So please, ask a question. And I want to start with a question for the three of you, which is, if you were king or queen of the world for the day, something I know you think about all the time, right? But if you were king or queen and you could wave your magic wand and have one thing, one policy change, one intervention, one public health program, any of that, one thing to help curb violence, gun violence, because we know that it's going to take more than one thing. But if you were granted the wish of doing one thing, what would it be? And please be specific, not descriptive. In other words, suggest exactly what it is that you would want to do. So,
you want to start?
Awesome, thank you.
You have to let the queen start.
There you go. He's learned well over the years. So I think that if I could do one thing to change the patterns of firearm injury and death in this country, it would be to develop an accurate system for identifying who is at highest risk of gun misuse, and then developing a program to separate that person from those lethal means at the time of danger. It's what we do in the emergency department every day. It's the basis of the public health approach, is identifying risk factors and then acting on them. And it is something that we simply don't know. We have a lot of platitudes out there about what puts people at risk, but there's so much that we currently don't know.
How would that work? I mean, the population coming into an emergency room is a very, contained and particular population. How do you screen everybody in the country?
So great question. So I would actually think that, the emergency department actually sees hundreds of millions of people per year, and so about a third of Americans actually come through our doors each year. So it is actually a great place to do almost universal screening. But if you combine that with primary care offices, schools, pastors, community groups, if we are all aware of what those risk factors are and then empowered to act on them, it can be tremendously powerful. Now, it's easy for me to say that we'll start with the healthcare system because it's what I know best. But we also, as we'll talk about over the course of the next hour, do a lot of work with community groups. And so there's a lot of space for empowerment there, too.
I think that's the key. There are a lot of touch points that we have out there. Again,
What's your one thing?
well, so
You can't just piggyback off hers.
oh,
Like
so,
you need to-
so I'm going to give you a very specific thing, and I'm going to be really quick because there's a very specific, and then there is a very short descriptive thing that I want to share with folks. My very specific thing that I would have us do is really teach medical professionals how to talk about safe storage of firearms. 50% of medical professionals don't get any education in safe storage, and 70% of medical professionals say they don't feel comfortable having the conversation. But that said, we know it is an effective intervention. And do we have any people out there who train medical students, who train nursing students, who train? I was going to say, at this meeting, we're going to have tons. We literally could do that overnight. We could do that overnight. Change the training, and you could change the dynamic, and you could actually save lives. That's my very specific thing. My more descriptive thing, and I'll be brief here, but it's very personal to me. I'm a gun owner, full disclosure. I keep my guns locked up in a safe. I keep my ammo away from my gun, so they're in 2 different safes. And we use our guns for to go out and shoot at the range. My son, today is his 18th birthday. And
Happy birthday.
he's actually with his grandpa right now. And his grandpa lives in rural Indiana, and they went out shooting today. And the very brief descriptive thing I would do is to help everyone see the world through each other's eyes. One of my favorite quotes is by Mark Twain. He says, "Travel is fatal to prejudice, bigotry, and narrow-mindedness," because you get to see the world through someone else's eyes. I've lived in Richmond, California. I've lived in Baltimore, Maryland, 2 of the most violent places in this country. And I've lived in apartment buildings in both of those 2 cities. My next-door neighbor having a gun was a direct threat and a real and present danger to me in those environments. I now live in Indiana, and my son, on his birthday, likes to go out shooting in the middle of a cornfield at targets with grandpa. So for them, it's family time. In a different environment, it is a very real and present threat to your life. And that's the challenge with coming up with national policy. How do you come up with national policy that satisfies people in Baltimore, Maryland, but also satisfies people in rural Indiana? It's a challenge, and that's why it has to happen at a local level. But it has to happen with us having a little bit of compassion and empathy for people who live in different environments and have different priorities than we do.
Okay, thank you. Chris, your
Right,
one thing.
so my magic wand, it would be kind of help to, I think, potentiate your wands. And that is, what I'm discovering here is that the public health approach that we're trying to operationalize is missing somebody, or a large group of people, which are firearm owners. And my one step would be to convene healthcare professionals who are expert in paramedics, nursing, emergency medicine, psychiatry, pediatrics, who are also experts in firearms or firearm trainers, and convene us with other firearm trainers and retailers to understand how we can integrate the responsible heritage and traditions of firearm ownership that we give in training with the risk reduction expertise of the health professions, so that we all understand that we are in this together. And I think when we do that, we'll find a lot of consensus. And then from that, we can enrich our processes for how to educate, how to talk to each other, and we can become ourselves trusted messengers in this community, whereas right now, we're not.
You are all 3 physicians. Is there something that you've done in your professional life or your personal life that was an intervention of some kind that you think may have prevented a gun death? Can you think of anything in particular? Megan, we'll start with you again.
How many particulars do you want?
If there's a bunch of them in one
Yes.
category, or
So I think, hopefully all 3 of us have stories of ways that we have intervened to make a difference. There's one story that actually stands out in particular in my mind. One of the things that actually got me started with doing work, I've been working in violence prevention for a long time, but one of the things that got me started in talking about firearm injury as a public health problem was a firearm suicide that I took care of in my very early days as an attending. In that case, sat with me. It made me question why we didn't talk about firearms as a source of health problems, as a source of injury and death, and why we didn't go upstream to talk about how to stop it. In doing that work, I connected with Jerome, with Chris, with a friend, Emmy Betts, who's at University of Colorado, Denver, and realized that when you actually counsel folks who are in the moment of a crisis around how to store their firearms safely, how to separate them from a firearm for the period of time that they're in crisis, you can actually save lives. And there have been studies showing that that counseling decreases the number of fatal suicide attempts by up to 2/3. So soon after starting doing this work, I took care of a police officer who came into my emergency department because he was having suicidal thoughts. He was very hesitant to come in because his job was potentially at risk. His wife actually forced him to come in. And he didn't quite meet criteria for being admitted to the hospital, which is so often true, more so now than ever before, right? Because we are in such a dire shortage of mental health providers. Now, I want to be clear that mental illness does not cause gun violence, right? We can talk more about that after. But for this man, who is in the midst of a personal crisis, the fact that he had his service weapon at home and could access it at any time was something that put him at much greater than average risk of dying. And he didn't want to give it up you can lock it up at the police department for a bit. That would have labeled him. He didn't want this to get back. So his wife actually locked it up and took the key. And that was the agreement on which I discharged him from the emergency department. He then went on to get care. I see him sometimes. We're a small community in Rhode Island, and he's doing fine. Now, can I say he would have killed himself if I hadn't done that? No. But quite likely, I saved a life.
That's great.
Can we dog-ear the conversation about mental illness, mental wellness? Because those are two different ends of the spectrum. And it is very true. We need to understand mental illness is not the huge predictor of gun violence that people say it is, but a lack of mental wellness is pervasive in our society and does lead to people making bad decisions all the time. So I hope we put a dog ear into that. But the intervention that I would talk about is one that we have at my hospital. So I'm a trauma anesthesiologist. I work at the Cook County, the Grady Memorial of Indianapolis. Whenever we're on call, we're taking care of the Knife and Gun Club. We're taking care of shootings. We're taking care of stabbings over and over again. And we had about a 30% recidivism rate. So the biggest risk factor, and this is both shocking and also makes total sense, the biggest risk factor for being shot is having been shot. And so
300 times greater risk of getting shot again if you've been shot once.
And so these folks are there. And in many cases, they're in our ICU for weeks, as we're helping them recover. It is a prime touch point for intervention. And we let them sit there and we don't say anything to them about how they got there. So our hospital developed a hospital-based violence intervention program. And this is now a CDC best practice. It was in their vital signs that they put out earlier this year that highlighted the 35% increase in homicide deaths over the last year. Hospital-based violence intervention programs where someone comes in, they've been shot, they've been stabbed, and you have an intense intervention with them while they're in the hospital. We lowered our recidivism rate from 30% to 4.5%. So we didn't save one life, we saved a lot of lives through that violence intervention program. And again, we need to help people understand that we can argue back and forth about gun control, and please don't ever say that. I beg you, please don't ever say that, because America was founded by people who didn't want to be controlled. You had people shut down when you use the word control. I say gun safety, but we can talk about that. But how about we talk about the evidence-based interventions that we aren't using right now, the low-hanging fruit that we know can lower from 30% to 4.5%, that we know can decrease by 2/3 the chance of someone actually taking their own life.
So can I tell 2 stories?
Sure, absolutely.
Darn it.
We didn't know that was an option.
Yeah, no. If you don't ask, you don't receive. All right, so these stories speak to how the health approaches that we use to address firearm injury are often nonpartisan and don't involve engaging law enforcement, because caring is not enforcement. Caring is not punitive. Caring is about care. And So many people have heard about red flag laws, and the intention behind red flag law is to identify somebody who's at risk, and then there's a legal process to disarm them, and this is very stigmatizing and difficult to discuss in a lot of communities. But the issue is to identify who's at risk, and then take that risk of dying or killing away. So a year ago in Vermont, where I live, there was a case of an older gentleman who had dementia that got more delusional, more paranoid in his dementia, and his granddaughter came to his house, and this is a case in the news, it wasn't my case, to prepare his food and his medications, and he shot her with a shotgun in the head and stomach, and she died. And this was an argument in the media afterwards that we need to reinforce and expand the red flag laws in Vermont. There's actually an easier way to prevent this from happening that's not so easy to measure, and that is anticipate the needs of our patients. So in the emergency department, I often see older people and younger people who are altered and identify that there's a risk. And when someone is altered enough or agitated that they become violent in their home and they start throwing pots and pans at their family members, and they're brought to me because they're unwell, well, then there's the identification that, well, this could escalate if there was a firearm. And since I live in an area where there's high rates of gun ownership, including me, I assume that the families have firearms. And so I ask, hey, so now that this person is decompensating, what are your plans for his firearms? And it's like, oh, that's a really good idea. And they make a plan for the firearms, and then nothing bad happens.
70% of doctors aren't comfortable having that
That
conversation.
Right. And so that's one example, right? I mean, I can't say that I have prevented this older person who is demented and agitated from shooting somebody, but we can compare from what's happening in the case. The second is an example of how we can create programming to scale out to health systems so we can train each other as healthcare providers, not just physicians, but nurses and paramedics, to give these interventions. And we piloted a couple of years ago a program called Reframe, about reframing this as a health problem, and my health institution in Western Massachusetts, because in the ER, we know when all the bad things happen, because you don't go in ER unless you have a problem, right? And
Most of the time.
and so we have, again, high rates of gun ownership, so higher rates of gun suicide. And a lot of the suicides are perpetrated against people who die by suicide are first responders, law enforcement, paramedics, physicians, and nurses. And we had a number of cases where people we knew in our community, because there's only 2 degrees separation between you and everybody else out where I live. We all knew each other. And we saw these cases happening. And so this was our moment to engage the community and our health system to address the problem that was happening in real time. We knew the national data. We also knew on a microscopic level our data. And so this was our moment to address it. And so we convened the community and my health system to talk about the case that we were receiving in our health system. And so we talked about 3 cases that were done in a confidential, in a compliant way, in a safe way. We talked about, this is a case that I had where a patient came to the emergency department. We recognized these risk factors. There wasn't much that we could do about separating them from the lethal means, or it wasn't even thought of, and then the patient died. And then with the audience, which was a community of not just physicians and nurses, but the community came, including members of the firearm industry, to talk about this. We talked about where were the opportunities upstream of that penetrating wound where somebody could have identified a problem and done something. And everyone decided that the best chance of intervention was in the family, in the home, when they recognized that there was a risk. And so then we gave some specific education about what we know about suicide, risk factors and warning signs. And then we gave 2 other narratives, one where there was a survival story, where somebody who survived a suicide attempt gave their perspective. And then we gave another story about a prevention narrative, where a physician talked to a patient, gave the intervention, and there was no bad outcome, to demonstrate this is something that we can all do. The very next week in my emergency department, there was a woman who came in. She was the spouse of a first responder who had hanged herself. And he came home and cut her down, and she was brought to the emergency department and could not survive. And one of our nurses who had attended the event with us had understanding now the context and who's at risk and why. And she was charge nurse that evening, so had no patient responsibilities. And so this first responder came in. She saw that he was despondent. She knew that he was at higher risk now because he had witnessed the death of the suicide of a family member. He had firearms. And so what she did is she went to his colleague and said, hey, he's at risk right now. talk to him about his firearms and make sure he's safe. And they did. And so that first responder is still in our community. And so there's a way that we can train each other to anticipate the needs of our community and understand how to pair risk with the opportunity so we can remove the risk of death.
Thank you. Those are all really great examples. I want to ask a question of you, Megan, and then you guys can chime in if you want to, but I think this is, you have all talked about gun violence as a public health problem, and you've written, in particular, quite eloquently about this.
Thank you.
And, you know, we noticed, my colleagues and I, that when you go to the CDC website, you see, for example, COVID cases, the numbers up to the very minute, stratified by state, by region, by age, by race. It's all right there. You don't see that with cases, as it were, of gun violence. You don't see it in real time. You see studies about looking backwards. I mean, you see that kind of numbers for, say, monkeypox, which is a relatively small public health threat.
Let it stay that way.
Yeah, please.
Yeah.
And what I'm wondering is, do you think, you know, a very basic part of public health and
data.
addresses data, is just simply keeping track of stuff. Why don't we do that, and should we do that?
That's a great question. For those, many of you I know are health or public health professionals, but there's really 4 steps in the public health approach, right? The first is having data. The next is, what are the risk and protective factors? Then you develop things and see if they work, and then when they work, you put them in place. But step 1 is data, and we have virtually none. So there are 2 big reasons that we have so little data. The first is, for 24 years, the CDC was basically effectively blocked from doing work on firearm injury prevention. When I first started giving public talks around firearm injury as a public health problem, you could not find firearms on the CDC website. You could find everything from aortic aneurysm to Zika virus, but firearm injury was missing. And that's because of this thing called the Dicky Amendment, which was passed in 1996 by a junior representative from Arkansas named Jay Dicky, who had been influenced by some political advocacy groups to believe that doing research was the same thing as advocacy. Let me be very clear, as the 3 of us talk about it, it's not, right? Collecting data and looking at data and actually finding truth around patterns is not the same thing as political advocacy. But Jay was convinced that it was, passed this amendment that forbid the CDC from spending money on gun, promoting or advocating for gun control. And from that time up until 2020, the CDC had no money to spend on this issue. Jay Dicky ironically said he was wrong towards the end of his life. There's actually a really nice piece in the New York Times today, a video interview between him and Mark Rosenberg talking about this. But that's the first and biggest reason, is there was no money, the CDC had no infrastructure. Then the second part is, because we're playing catch up, imagine we had no data on heart disease for 24 years. Imagine we had no data on oncology, on cancer for 24 years. We're now trying to play catch up, and we're using data sources that are incomplete or inaccurate. And so a couple of years ago, a few of our colleagues actually identified that the injury data that was on the CDC website was horribly inaccurate. And so the CDC took it down, and they're now trying to develop better systems for collecting real-time data, but it relies on the hospitals actually coding it correctly and then having a system to report it in. That all takes money. And as we've learned with COVID, one of the reasons why we have the COVID data is actually because we've declared it a public health emergency and almost forced the hand of, and Jerome can talk all about this from his experience in Indiana, but almost forced the hand of state and county health officials to provide us with real-time data. Nobody's doing that for firearm injury. And so what we do instead is we rely on things like the Gun Violence Archive, which is an amazing program that tracks all of the media reports. Some cities, like Philadelphia, have developed programs to track shootings in real time. There are a number of physician groups that are trying to use data. But it is, I mean, Elizabeth, it's mind-boggling. But to your point, like, how do you start solving the problem if you can't even measure it?
But why doesn't the CDC do something like what the Gun Violence Archive does? As imperfect as it is, I mean, going through media, God knows how irresponsible we are, right? I'm just.
You guys are. Depends on which outlet.
Right. But if that's the only data, isn't that better? And put a little note there that says this is, you know,
so
because it could take eons.
It could. So it's a great question. So I'm actually a big believer in citizen science. You know, I started this organization called Get Us PPE during the pandemic that Chris helped with as well. A firm actually helped support that served as the preeminent source of data on which healthcare facilities, both acute care facilities and non-acute care facilities, had PPE access. there was some tracking on, I don't know if Alex Azar is here or not, there was some tracking on the part of HHS, but it took a while to, and you can talk about this as well, but it took a while to ramp up and was inaccurate and didn't include all of the healthcare facilities. We made a huge contribution that was then kind of taken over by the federal government. So I would hope that the CDC would take it over, but there's a lot of laws and regulations that the CDC has to follow, a lot of extra steps around verifying data that are sometimes prohibitive from quick change.
I think you put that very well. This isn't a problem that's unique to guns. I had an op-ed in USA Today several weeks ago where I talked about the fact that in March of 2020, the President of the United States asked me how many COVID cases we had. I don't know, Mr. President. How many ventilators do we have? I don't know, Mr. President. How many hospital beds do we have? I don't know, Mr. President. And then he said something not so nice to me. But the truth is that, as Megan laid out, we don't have reporting from hospitals. We don't have reporting from nursing homes. We had less than 60% reporting even after begging. And finally, we had to use public health authorities and the threat of either taking away people's money or the bribe of giving people extra money to get them to report. And the interesting thing is that that actual authority is about to go away. So we talk about the COVID dashboards. That may go away if we don't change the laws soon, but that's cardiovascular disease. That's opioids. We should have better real-time reporting of opioids. It is a basic problem with data collection and infrastructure at the CDC, and we need to fund that at a basic level for every disease out there. There's no reason, we've proven we can do it with COVID, so we should be doing it. You're right, we should be doing it, but the other point Megan brought up, which I want to foot stomp, is there are laws, there are regulations, there are rules, and as you've seen with COVID, the CDC has to be 101% correct before they put something out, because if they're 1% wrong, then everybody goes, see, you can't trust the CDC, and that is a real conundrum that they have over and over and over again, that they have to be perfect. And it was a frustration for me when I ran a state Department of Health. My epidemiologist would say, we've got to scrub the data. We've got to make sure it's perfect. There's that pressure. And they're starting to shift just to, your point, put up provisional data. But then the public has to understand that it's provisional data. It may change, and that doesn't mean that someone was wrong or nefarious or incompetent. It means that it was provisional data.
Yeah. But this is the point of also funding the research, is because we develop the systems, we develop the methods that then inform everyone else. I'm going to give an example. There's this amazing project called the Violence Project, which is run by a couple of folks out of Minnesota, that has tracked every mass shooting over the last 3 or 4 decades and looked at the risk factors for being someone who commits a mass shooting, and has used this. They have done this with largely private funding, actually, largely philanthropy, and have managed to identify what are the most common risk factors for being someone who is going to be a mass shooter. There's a suicidal impulse, there is a personal crisis, personal distress, which, to your point, and I see John LaPook in the audience, and he did a great piece for CBS on this recently, which I want to highlight. But there is a difference, right, between personal distress, between psychological distress and mental illness,
Yes.
right? Which, so they've identified that in this violence project, and then we're then using it to say, how do we inform those of us in the emergency department, people in schools, Secret Service or FBI, to better identify who's at highest risk and intervene. My hope is that that work that's being done privately will then be incorporated eventually into our larger national guidelines, right? That's how this works. That's how science works, is you do these little experiments, and if they're successful, that's awesome, and then you put it onto the national stage. But for the data, we're so far away still, again, because we've had 24 years of not doing it.
Let's take some questions from the audience. If you can raise your hands, and don't start talking until until you have a microphone. So sorry, I don't see very well, but I think I see a hand back there. Am I right about that?
There, and then one there.
Okay, yeah, someone has their hand up back there. I see a microphone headed their way.
Okay, thank you. My colleague and I are physicians practicing in this area in the congressional district represented by Lauren Boebert. So I would really love, I think all physicians kind of develop a spiel about different topics that they talk to patients about, and I would be really interested in hearing each of your spiels when you talk, and obviously we change things depending on who you're talking to, but your general spiel when you're talking to a patient about gun safety?
May I ask, what kind of physicians are you? Do you mind? Because it differs, right? If you're a pediatrician or an anesthesia, you know.
Right.
Yeah.
I'm an internist, and she's an ER physician.
You know what, give an example. If a patient comes in, give a little scenario, and then they'll pretend to address that patient.
So I had a young diabetic man come in a few years ago carrying his gun on his hip, which we don't allow, and I had to talk to him about that. But I realized I sort of ineptly tried to take it a little further in terms of safety, but he knows so much more about guns than I do that I felt inadequate.
Well, and that's to Chris's point. One of the things that I personally do and say is that, hey, I'm a gun owner. I mean, because a lot of the conversations start off with them thinking the second you talk about guns, you want to take away their gun. And it's immediately defensive. It's immediately they're putting up their armor. The last thing that, quite frankly, a lot of them expect me to say is, hey, I'm a gun owner. And here's what I do to keep my gun safe. And it opens up the ability to have that conversation. And not every physician is going to be a gun owner. You're not going to be able to, but the point is that we've got to be able to, there's a saying that I love, and it's that people need to know that you care before they care what you know. And we have to find that connection point with gun owners that is not we're going to take away your guns or you're a bad person for carrying it connection point, and show them that we care. And then we can start to have that conversation. That's the way I approach it. It's going to be different.
And to build on that, so I've never actually had a difficult experience thus far talking to my patients about firearm safety, because I tell them why I'm talking about their firearm. Because I identify I am concerned about a health outcome for yourself or your family, and therefore I want to ask you about your firearm and how it's stored, and if there's an opportunity for, in that moment of crisis, to separate you and the firearm for a period of time. If a patient comes in and doesn't show a risk factor or doesn't demonstrate evidence of being at risk of harming themselves or others, I don't bring it up.
So I am the non-gun owner of the three of us, right? So I will kind of say that I can't use that as my starting point. I also get that as an internist or as a pediatrician, there's a responsibility for anticipatory guidance. Yep. And so in those settings, I frame it in that larger set of questions, right? So tell me about, do you wear your seatbelt in your car? If you ride on motorcycles, do you wear a helmet? If you have little kids at home, do you have the poison kind of taken out from underneath the sink, or do you have a sink, one of those kind of locks in place? Oh, and do you have a firearm at home? If so, is it stored safely? And they may ask why you're asking. And so then you can share information about, listen, I want to make sure that if you have kids in the house, that their friends can't get access to it. If you have an elderly parent, that they can't get access. And then, of course, God forbid, if someone in your household had kind of a personal crisis, I would want to make sure that there was space and time between them and the firearm. But I take this harm reduction approach. I use that same technique that I use with motivational interviewing when I'm talking about any other potential health risk, ranging from the risks for heart disease to the risks for car crash injury, and allow the patient to make the choice that hopefully decreases their risk a little bit, unless, of course, they are in a very high-risk situation, in which case you get a little more prescriptive.
And Megan talked about harm reduction. This is a real scenario. I've had conversations with people in gangs about their gun ownership. And I'm not going to talk them out of carrying their gun, because they're carrying it to protect their life. That's just a non-starter. But I can have a conversation with them, and I have when I notice they have a kid. Mm-hmm. And that's another place where I can create connection points with people. Any of you who'll meet me or who've met me before know the first thing that I do, and it's just natural, it's not contrived, but I ask about people's families. I ask about their kids. I love talking about my kids. Mm-hmm. I mean, what's the first thing that wasn't even planned. I talked about my kid to you all today. You create that connection point, and okay, well, you've got a kid at home. So I understand you feel like you need to carry your gun, but what are you doing to keep your gun out of reach of your child? What are you doing to keep them safe? And so, again, not judging, not coming in and saying we're here to take away your gun or making it seem like that's the case, but creating that connection point and then finding some common ground so that you can reduce harm even if you can't completely take it to zero.
And I'm happy to share resources afterwards. There's a whole group of things. We've written papers for Annals of Internal Medicine. There's a whole project out of UC Davis that has lovely counseling language as well. So happy to connect you afterwards.
See, I think we have a question right here.
Thanks so much for coming. So my question is this. My brother is the head of a department in France. He's an anesthesiologist in the emergency room and trauma. And I was talking to him the other day because of what's happened recently. And his point that he doesn't understand, and neither do I, so this is my question, is in France, in his emergency room, which is filled like ours, there's hardly ever somebody coming in from a gunshot wound. Right. And the reason is because no one has guns, and no one needs guns to protect from people who have guns. Judging from that and places like New Zealand and other places in the world that have just said these are used to kill mostly, other than shooting with your grandpa and things like that, why can we just not eliminate that like other countries have? They've proven, talking about data, that their data is once they eliminate the guns, the death from guns stops. Why is that so impossible?
So can I take this as someone, no, so thank you. So as someone who is not a gun owner, this was my viewpoint coming into this debate, right? Is if we just got rid of all the guns, there would be no gun deaths, right? Which is true. And if we got rid of all the cars, there would be no car deaths also. We haven't gotten rid of cars. Instead, we have used the public health approach to decrease the number of car crash deaths by more than 70%, despite the fact that there are more cars on the road and more millions of miles traveled than ever before. We have used this public health approach to change the engineering of cars, to change the engineering of roads, to change education around car seats and drunk driving. Yes, to put some policies in place as well to help license people more effectively. Now, are there people that drive with suspended licenses? Are there people that drive drunk? Are there still car crash deaths? Yes. But we have managed to maintain folks' access to cars and still decrease deaths. In our country, firearms are not going away. There are more than 400 million firearms in private hands in the United States. And when we say things like, the answer is to get rid of guns, do you know what happens? Nothing. It actually stops the conversation, it stops us from making progress, and it stops us from creating that equivalent of that 70% decrease that we have seen happen for car crash deaths. If we had said then the answer, when they tried back when the very first car crash happened, back in the early 1900s, if you read the history of science and medicine, they said, oh, we have to get rid of cars. We have to, imagine, I mean, you know, some folks, the Amish, I grew up in Buffalo, New York, there were a lot of Amish around. They don't have cars, but for most of us, we can't imagine that, right? And instead, there are things that we can put in place to make firearms safer, to make the people that use them safer, and to create systems to reduce access to those who are intent to harm themselves or others. So that would be my answer.
Chris?
Well, also, you know, the public health approach requires that we develop programs with the communities and for the communities. And what works for New Zealand and France and other countries is appropriate for their population. It's not appropriate for the United States population where we have the Second Amendment. And so firearms are here. We accept that. We want to be as safe as possible and learn how to live safely with and around firearms because they're part of our culture, and we're not contesting that.
And from a political standpoint, and I just want to add on to that really quickly, and I'll be really brief here. The real challenge is that there's the world as we may want it to be, and then there's the world as it actually is. And as physicians, we have to operate in the world as it is. But from a political standpoint, the one thing that I would say against what Megan said is she said that nothing changes. Actually, when you threaten firearm ownership, gun sales go up. Mm-hmm. Gun sales consistently go up whenever someone is running for office who says, I'm going to take away guns. And so we actually make the problem worse. And so while I hear you, and while I appreciate exactly what you said, that yes, if we could take away all guns, it would solve the problem. You are correct, but we're trying to help people understand that there are real, tangible things that we can do right now to make people safer. The VA has done a tremendous job with safe gun storage that has really lowered suicides in the VA. There are real things we can do right now short of taking away everyone's guns, and we aren't doing those things because we're fighting over whether or not everyone should have guns or no one should have guns.
Oh, sorry.
I want to speak to what you're saying, which is we live in the real world.
Yeah.
And I also want to speak to the applause that question got,
Yes.
which is this. Everything that you said about reducing car accident deaths is true, but you left some things out, including there is now a law that car makers have to put seatbelts in cars, which they fought tooth and nail at the time.
Yes, they did.
Back in the day.
Ralph Nader made his name.
Exactly. There is a law that people in cars need to wear seatbelts, which was also fought tooth and nail. But they work, right? Now there are seatbelts in cars,
Totally,
and
Elizabeth.
people wear them because it's a law.
Right.
Is there anything wrong with making laws? For example, a law that says, you know what? You can't buy an assault rifle until you're 21. What would be so terrible about that?
So I love this question. I love this question. And I want to be clear, and when I talked about car crashes, I actually did mention policies. Drunk driving laws are one of the most effective things that we have to reduce car crash injuries and deaths. And there are absolutely policies out there that are effective. And I will say that if this closure of the boyfriend loophole passes, I will be one of the happiest people in the universe because I have taken care of patient after patient who has been shot by their partner. I have a friend who was shot as she walked out of her shift in the emergency department by her ex-fiance and killed. And many of us have those stories, right? And that is a place that policy absolutely makes a difference. But policy alone is not sufficient. So actually, when you pass drunk driving laws, the law alone is not what does it. What does it is the enforcement and the education on the other side. My state has actually closed the boyfriend loophole, and nonetheless, I take care of women that have been shot by their boyfriends, who they have restraining orders against, or who have been convicted of domestic violence, because we have not done the work to educate our family court judges or to educate the law enforcement officers. I will call law enforcement when I take care of a victim of domestic violence and say, she says that her boyfriend has firearms, and they'll say, well, if we run into him. And I'm like, are you kidding me? So there's this element of policy and. So there are policies that are tremendously effective. They need to be used in a way that's matched by implementation and education. And so there is a thoughtfulness behind what we put in place that's really important. And it's actually another part of this kind of Senate bill going forwards of providing money to states to put red flag laws in place. It's critical because you could have every state in the country could have a red flag law, and I can tell you most states don't actually use them effectively. So there is this kind of, it's a both and rather than an either or. And I think the mistake we all make, or many of us make, is thinking that policy alone is going to solve this. Policy is absolutely part of it, but it is far from sufficient. And if we lean only on policy, we then lose the chance to do so many other things that create space for collaboration and forward movement together and that are tremendously effective.
I love one of you said the term low-hanging fruit. And for example, what you do at Purdue, like it's crazy that that's not done everywhere, right? Isn't it low-hanging fruit to tell gun shops already check what age you are? They don't sell to 10-year-olds, right? I mean, They want you to be 18. Wouldn't it be pretty low-hanging fruit to say, you know what, when you're selling assault rifles or whatever the right nomenclature is, that person has to be 21. That sounds pretty simple. They're already checking IDs. They're not selling to 6-year-olds.
Well, and that's what they're actually talking about right now with the bill that's out there. And so,
but it's not. I don't think it's looking so hopeful.
It's not. But to your point, I'm a gun owner. I'm not an NRA member, so that's my.
Are you over 18?
That's my full disclosure.
Are you over 18?
That's my full disclosure. I'm not an NRA member, but the NRA member has done a masterful job of saying, we can't let them do that. Because see, they're gonna that's a slippery slope to them taking away your guns. And we say we don't want to take away your guns. Oh yes, we do. Did you hear all that applause? This is all on it's all recorded. It's all. That's exactly what they want to do. They want to take away your guns. And the NRA has done a masterful job of creating this all or none. That if you even, as a elected official, give them 1 inch, if you let the camel's nose under the tent, that's going to be the slippery slope to us taking away your guns. And that's why, again, we are so, I completely hear you, sir, and I hear you all, and I feel, we see these people in our emergency rooms and our operating rooms every single day. We are just as sick about it as you all are, so please don't mistake what we're saying as us not being as passionate about it as you are, not hearing you, but we've seen also from a policy perspective that taking that position can actually hurt
The chance
our
for
ability
forward progress.
to move the ball 4 yards down the field versus 100 yards down the field.
Right. When you lead with policy, you disengage this population that desperately wants to be part of the solution. And so, again, this is the policy is the fourth step of the public health approach, scaling up what works. And we don't know that these policies work. We don't know if changing the law from 18 to 21 for assault rifle will actually have a change in outcomes. We don't.
No, we know that, I mean, the 2 recent shootings were 18-year-olds who legally owned guns.
I understand that, but the thing is, we can't drive the public health approach with policy. Because when you do that, you make it impossible to engage communities who can help us bring the ball 4 yards down the field as opposed to
Great analogy.
So would you be against a law that said no sales 18 to 21?
What I think personally is not relevant to this conversation. What matters to me is this person safe? Like, as far as I'm concerned, if you're a safe person without risk factors for harming yourself or others, then I'm not going to personally get involved in that.
I would be in favor of it. I mean, I would, and I've told my Republican colleagues. I've talked to Bill Cassidy. I've talked to Senator Young, and there are 2 of the Republican senators who have crossed the aisle to support the bipartisan legislation. But I say it from the standpoint of, hey, we know that the brain is not fully developed. We know that there are medical and scientific reasons for not giving someone the ability to own one of these weapons. And then the data that we do have, to your point, does show that that several of these shootings, we have to collect the data. We can't just do it based on feel or emotion or because someone did it over in another country. We've got to do it based on what we know here.
Let's see.
Ooh, that could
Oh,
a
wow.
whole lot of questions. I like it.
We're never going to.
While we're getting the questions out there, so I want to add one more thing, which is you look at prohibition, right, which was a great idea, and think about how poorly it worked.
Do you mind if I hold it, just so we don't want to pass the mic to
Okay, so this is a slightly different perspective as an engineer.
I love it.
So-
Yay, engineering, a great
So-
public health solution, by the way.
So cars are designed for locomotion purposes, but guns are designed to kill. I mean, there is no other purpose for
Yeah.
it. And engineers designed it for wars or for preventing that. They're not designed for civilian use. So and especially like big magazines weapon, they were never designed. So we have to understand that the big argument of why we are facing this as a nation is because there's an advocacy from NRA very actively there. And I really appreciate you dealing it as a public health issue, because it is a public health issue, and that will help. But eventually we need to get to the point that what they're designed for, they're designed to kill.
So do you actually think, and this is just a question I have for you all, again, don't disagree with you. Do you actually think in our lifetime we're going to get to a place where you're going to get enough people people in the United States and enough of our legislators to agree? And if the cost of pursuing that is that we aren't doing all the other things that we mentioned in the meantime, then is that a cost you're willing to accept to move in that direction?
So
And then sorry, go ahead.
please.
Answer his question.
I don't want to take anything away from what all 3 of you are doing, because that is really helpful. So there is no doubt about that part. So really appreciate that approach. But I think as a father of a 15-year-old, I worry every single day.
Yeah,
And
I do
at some
too. I've
point
got
of time,
17,
there are other
16.
parents who should stop worrying, because there is a group of people who, because of relates to COVID in a way, that I'm not doing something because it affects your health. At some point of time, we have to come together as a nation and see what is of better purpose for everyone. And unless we get there, I think we'll have these issues.
So
And I know it's not
totally,
simple.
yeah. And as a parent of a 13-year-old and a 10-year-old, and you have a 16-year-old and a 13-year-old, right? So totally with you on the need to protect our kids and protect our communities. And I think that our perspective is, what is actually going to get us there to protect them, right? And I think that to me is the core question of, where can we actually go that is going to protect our kids? It is not arming teachers, right? It's also not making our schools more secure. It's about doing a better job of getting the folks that are both at highest risk and the folks that can help change this on board with the need for a shift. I will also say from the engineering perspective, there are some amazing engineering innovations that were put in place, to your point, with the car industry kicking and screaming, right? Crumple zones, 3-point seatbelts, making seatbelts mandatory. We have not done that for firearms. So yes, they are designed with a certain purpose in mind. There are also ways to make them safer, right? So everybody loved their gorgeous Cadillacs, right, with the steering wheels that would impale them, literally. And we don't see that anymore. And we don't see that because of engineering. So there are also really smart engineering solutions out there, some of which we've only started to think about. So I think that kind of the thing that we're trying to say is, how do we think outside of the box? We have been going down this one road, which is for as long as I have been an emergency physician. And all I'm seeing are gun deaths go up.
Right.
So how about we try something that might be, actually help us make a difference?
And two other points to that. So there are probably about 100 million gun owners in the United States right now. And there are probably closer to 500 million guns in private ownership.
No one knows.
We don't know. But according to some older surveys. So with that many millions of guns and gun owners, we have 45,000 deaths and 140,000 injuries per year, which is a terrible number. However, that would suggest that gun ownership, especially legal responsible gun ownership, is very safe. And moreover, what we pursue, the approach that I take is I understand, and there's consensus in many groups about this, is that how a gun can be used depends on its manufacturing, how it's designed, and so forth. But how it will be used depends entirely on the health of the person holding it, their mental, physical, and social health.
How does that number suggest that they're safe?
So, how many cars in the country versus how many drivers versus how many car deaths? I'm not contesting, I'm not arguing that. I'm saying based on the number, what is that, point?
So I'm actually gonna move, So if you want to say, so do you know who's most likely to die from a gun injury in this country? It's young black and brown men. Mm-hmm. So it's 20 to 30 times the risk for so you want to know how to help save them? It's about getting rid of vacant buildings. So there have been studies showing that when you green vacant lots, you decrease the rate of gun violence in the neighborhoods around that. It's about funding public schools. It's about providing educational opportunities and mental health treatment. And it is about stemming the flow of illegal guns. Absolutely, it is about reducing access to the means for someone who has the intent to harm others, right? And that is part of what is in the bipartisan bill. However, there is the reality of the fact that I live in Rhode Island, which is a very blue state with relatively low rates of firearm ownership. The vast majority of Americans do not live in Rhode Island or in Brooklyn or in Berkeley, right? The vast majority of Americans live in a place where somewhere around 40 to 60% of homes have a firearm in them. And we have to start by understanding what our fellow Americans are living with and then creating solutions that help to protect them and protect their children, right? Anyone that you talk to in this country does not want their kid at risk. Anyone. And so let's work with the communities that are in Detroit or St. Louis or Gary, Indiana, which has one of the highest rates of firearm injury and death in our country. Let's work with them to actually make the investment to decrease, let's address the structural racism that puts those young men at risk. 100% all day long. Right?
Let's prevent. By the time we're debating over whether or not the person should have a gun to commit a violent act, we've missed so many opportunities, and there is great data. There are great programs in Chicago, and I visited south side of Chicago, a great program where they took young men who were
Bernie
either
Duncan's work.
Yes.
Yes.
Took young men, and I visited with some of these young men who were at risk for committing a violent act or being a victim of a violent act, and they gave them peer mentorship and helped them understand careers that they could pursue, and they precipitously decreased the chance that they would be involved in a violent act, statistically speaking, more so than trying to take away the 500 million guns that are in the United States that they would otherwise get.
And there is an aspect of kind of also, I'm going to say there is an aspect of kind of the firearm dealers, right? So there are these notorious bad apple dealers, there's straw sellers. There are some really good policies that could be put in place. The ATF absolutely needs to be empowered to do a better job talking about
It's
data.
yes and, it's not either or.
Right,
It's yes and.
We only have 5 more minutes.
Sorry.
Well,
But can I just say, yes,
Young lady up front here, but go ahead.
Really quickly, something that we're missing here is we keep talking about the firearm victims as the people who got shot. What about the people who actually end up in jail? And I talked about making the economic argument earlier. Do you know it costs $150 a day to incarcerate someone? Times 365 days a year means it costs about $50,000 a year to incarcerate someone, which means someone gets a 20-year prison sentence for a firearm, for a firearm felony. We're paying $1 million to incarcerate them. We need to help people understand the financial cost and the societal cost, the workforce cost. We've lost someone from the population. We're paying $1 million to incarcerate them. We need to help them understand that, yes, as tragic as those 45,000 deaths are, the toll is even much greater, particularly, again, in Black and brown communities.
Question right up here in the second row.
I'm going to hold it for you if it's okay. I'm sure.
Yeah, thank you. So I'm a primary care physician, and I do counsel about guns. Thank you for teaching me how. I work with Emmy Betts. She's fantastic. And my experience counseling about firearms is very similar in a lot of ways to my experience counseling about vaccines, which is that when I tell someone that they are more likely to be hurt by their own firearm than to defend themselves or their family with it, which I believe is what the data shows, they do not hear me.
Right.
And I cannot communicate that to them. And I hear what you're saying about how we need to find common ground with everyone, and especially with people who own guns. And I wonder in what way education is a part of that and how we should be implementing that.
There's actually been some great studies. Mike Anestis, who's at Rutgers, has done some really nice studies looking at actually who are the trusted messengers among the firearm community. And you're right that for most things, and this is where the anticipatory guidance gets tough, it's actually not us. And so actually, you know who's a trusted messenger is military, police officers, and fellow firearm owners. And so the work has to be with those groups.
Right, and that's
Which goes back to this point of when we start by saying, well, we're just going to take away the firearms, we then cut off the ability to work with all those groups that actually can make a really, really big difference in terms of the patterns of firearm injury and death in this country. If you actually want to talk about saving lives, it's about finding ways to work together with people who may have different belief systems from you, right? But there's no way forward in this country if we don't work with people who have different belief systems from us. So that would be, I think it's totally expectable, but we have to do that together.
Do we have time for one more question or a few more questions?
Thank you for working with Emmy.
One more question. Okay. Let's see. I'm trying not to just favor the folks in the front. There, in the back, someone's going like this. You win with the.
Should be noticed.
Thank you so much.
You know my number.
Oh, you hold it. I'm so sorry. I'm very eager. So first, I just want to say that I'm coming from Oklahoma, the first state in the nation to enact an anti-red flag law, very proudly on their part. And I also want to say we just had a mass shooting at our local hospital, St. Francis, and lost 2 physicians, a hospital staff member, and a patient. And so I just want to lift them up in this moment. And, you know, I know that it's probably scary to be a physician right now because of gun violence as well. So I wanted to go back to what you were saying, Dr. Adams, about the recidivism decrease that you saw from 30% to 6%. I wanted to know more about that specific intervention. And then I also wanted to hear, I love that you brought in infrastructure. I know that like lights can decrease crime in a neighborhood. So what other like violence interruption or interventions, like transformative justice, resolving harm and conflict without police interaction, like things that de-escalate and do harm reduction, what interventions have you seen work really well? And I want to hear about the specific intervention you brought forward.
Well, all of us know about these hospital-based violence interruption programs, but really, it starts with just having a connection, having the conversation with the individual. Peers are really helpful. If you can bring in someone else who's been there before, who they can relate to, that is incredibly helpful. Conflict resolution, teaching them skills And they did this in Chicago with the young people also, teaching them, in many cases, you've got a young man who has no male role models in their life. They don't know how to deal with a conflict other than to pull out a gun and go shoot somebody. And so teaching them basic conflict resolution skills is important. Helping them get job training is incredibly important. I remember when I was in Chicago, I talked to a young man and he said, there's not a male in my family who's lived past 25 or with either alive or not in jail. So they don't see, if they don't have hope for a better future. I mean, I get angry, you know, and there's a lot of reasons I don't go out and shoot somebody, but one of them is I don't want to lose my really good job, you know? And I hate to be facetious there, but we have to give people hope and a vision for a better way forward. Otherwise, they're choosing amongst a whole bunch of bad options. And we're blaming them, but they don't have a good option to choose from. So
Right, and there are opportunities to work with the firearm community, you know, because they have control of the act. They can deter people whom they recognize to be at risk. There are firearm retailers that are already turned down sales to people who demonstrate concerning behaviors. So if we can create education collaboratively that's voluntary, that everyone can use, then you can have interventions at gun ranges, at training facilities, at health systems, and so forth. But we can't get to these opportunities for violence intervention that's multiple layers without actually all of us coming together and being cooperative.
can you talk about greening?
Yeah, so this,
I love
thank
this.
you.
I
So
love
this is one of my favorite. There have been studies in Philadelphia, Detroit, and elsewhere that show when you take a vacant lot and put a garden in, or when you take an abandoned building and beautify it and turn it into a community center, it decreases the rate of firearm injury in the neighborhood just right around, like these directly surrounding neighborhood, decreases the rate of firearm injury, or the number of gunshots by around 5%. Also decreases stress, depression, anxiety, other stress-related disorders. So a super simple intervention, which is putting in a garden, showing people in the community that we all care and we're in this together. And you now have a peaceful and calming place to go instead of walking by a vacant lot that's littered with broken bottles or kind of whatever. So that's one. Yes, putting street lights in absolutely makes a difference. Improving our school systems. Big Brothers, Big Sisters is one of the programs actually on the CDC's list as well as on Blueprints, which is an incredibly well-proven violence intervention program. And so I think if you guys take nothing else out of this talk, this is one of, I think, the most frustrating and divisive issues that we face as a nation. And we can choose to let it continue to divide us, recognize that we all have very real personal reasons for hating that this problem exists. And, right, we can feel very kind of sad and hopeless, and or we can choose to try to find paths forward that are maybe a little bit out of the box, but that address those root causes. The same way that I want to have a system to treat heart attacks really quickly when they come to my ED or to treat strokes, I also want to have a system that keeps people from having heart attacks in the first place. And so it's about thinking about kind of what is that bigger picture of, and I love your question as a closing question, as a chance to think about what are those structural factors, what are the things in your own community that you could do or be part of to help create this change. I think back to the young woman who talked in the opening ideas about the social and emotional learning in schools as another great example of something that helps our kids who may have no role models how to deal. And so it's going to be a group. And when you asked for the magic wand, I struggled, Elizabeth, because I thought about this. And I'm like, there's no single magic wand. And that's the reality. We have a long ways to go.
Oh, I didn't mean that the intervention would be a magic wand. I meant that you had a magic wand to make one thing happen. Right.
Well, see, that's why I struggled. I missed it.
And I want to leave you with a parting thought that's a little bit different and provocative. But as Surgeon General, I put out a call to action on really doubling down on the national strategy for suicide prevention, because there's a lot of these interventions that we've talked about are in the National Strategy for Suicide Prevention. We just haven't implemented them. And why is that so important to me? Well, it's important to me, number one, because I'm a veteran, and we know veterans are at particularly high risk. But it's important to me because, and here's the provocative part, and I want to leave you with this. I would argue that every mass shooting, or most mass shootings are suicides. I would argue that because if you're going to pick up a gun and go out and shoot a whole lot of people, you know that your life is essentially over after you commit this act. It is essentially a suicide attempt. in these inner city communities. These folks who are out there choosing to pick up a firearm. In many cases, they know, I'm going to jail for the rest of my life or I'm going to die. These are suicide attempts, and the actual data shows that in mass shootings, 1/3 of the people who commit mass shootings reported, you can go back and find that they had suicidal ideation, suicidal thoughts expressed beforehand. So the parting thought I want to leave you with is that suicide prevention is mass shooting prevention, is homicide prevention. If we do the things that will lower suicides in our community, including embracing and making sure 988, which is going to be active on July 16th, has the resources to actually take care of the calls that come in, then we will actually lower all firearm injury across this nation.
Thank you for that closing thought.
Thank you.
Thank you for that closing thought. Thanks.
Thank you all.
to both
Thank you
of
for your passion.
you.
Thank you so much, and please,
you for caring.
pick one thing. Pick one thing and just try to improve your community, as Megan said.
Thank you. Thank
Thank
you
you
all.
all for
Happy to stay after for questions.
Thank